Thank you so much for joining us this evening. I want to thank Inari Medical for providing this amazing platform to be able to teach you some important concepts that we're going to discuss tonight. My name is Julie Cardoso. I'm the CEO of Universal Ultrasound and also the technical director here at Advanced Heart and Vascular Institute of Hunterdon in Flemington, New Jersey. The topics of discussion that we're going to be talking about is the assessment of the lower extremity veins as well as the iliocaval system. We're going to be talking about normal anatomy and physiology and also different pathologies that we see in the lower extremity and also in the outflow veins, which is typically in the outflow veins, DVT and compression, and sometimes a combination of both. Now we are going to scan a real patient tonight, and tonight I have Barbara here. She is a frequent flyer in our facility. Barbara, we've been scanning Barbara since 2020, so a little bit later in this presentation, we're going to take you in a time machine and travel back to 2020 and show you what her outflow vein assessment was at that time, and then take you back to present time, what her outflow veins look like presently. Just to let you know that this is an interactive platform, so please, I'm here for you. So type in all your questions that pertain to your facility or any questions that you have as far as physics, ultrasound findings in the chat, and I would like to talk to you about them live here. If not, we're also going to be doing a 30-minute session together. I look forward to meeting all of you, and I want to answer all of your questions. But before we get started, let's get everybody on the same page as far as what the normal anatomy and physiology is of the lower extremity system. So I'm going to go ahead and pull up a slide here. And I want to make sure that we understand that the lower extremity veins, there's two systems. The first system is the superficial system, which is located outside the muscle fascia near the surface of the skin. Now, believe it or not, this system only accounts for about 5 to 10% of the blood flow back to the heart. And what is the superficial system? Well, we have two veins in particular that we look at. One is the small saphenous vein that originates at the ankle and the posterior calf and has multiple confluences. And why I say that for you as the investigator, as a sonographer who could be working with the interventionalists that do thrombectomy work, you want to make sure you let them know where the small saphenous vein confluences into, because sometimes it doesn't always confluence into the popliteal vein. It confluences into the gastrocnemius vein, or it extends up the back of the leg. The next vein we're going to talk about is the great saphenous vein, which happens to be the longest vein in the body that starts anterior in the calf at the ankle and then goes more medial in the thigh and then confluences and the groin area at the common femoral level. The next system we want to talk about is the deep venous system. Now this system, as we know, is located deep within the muscle fascia. And this muscle, particularly the soleus muscle, is the calf muscle, acts as a pump, and this allows venous return to the heart. And this accounts for 90 to 95% of the blood flow back to the heart. So what is the deep venous system? Well, in the lower extremity, we have paired veins in the calf. So the paired veins are the paired posterior tibial, peroneal, anterior tibial that confluence into the below knee paired popliteal vein, and then at the knee crease becomes one larger vein, and then into the femoral vein. Then at the groin area, the deep femoral vein and the femoral vein confluence together to create the common femoral vein. So as we go into the groin area, the common femoral vein dives deep into the pelvis, into the external iliac vein. And once we get about to the umbilical button, the belly button area, we have the internal iliac vein and the common iliac vein that confluence together. And then that comes and forms the IVC, and that enters into the heart. Now, like I said earlier when I was talking to you about Barbara's story, we have to think about different pathologies that we see in the deep venous system. And the one pathology in particular is DVT, deep vein thrombosis. Now, how does this occur? Well, Rudolf Virchow came up with these three factors that contribute to DVT. So one, as in Barbara's story, like I told you earlier, is a hypocoagulable state because she had cancer. She's a cancer survivor, so she was on chemotherapy. The other is an acute phase that's post-op, a thrombophilia, estrogen therapy, pregnancy and postpartum period, or believe it or not, IBS. The other factor that can contribute to a deep vein thrombosis is endothelial injury. And that occurs when a patient has trauma to the body, surgery, any catheters that are placed, atherosclerosis, and believe it or not, heart valve disease or replacement. The third factor is venous stasis. And venous stasis occurs when the patient is not mobile or sometimes, most of the time, they're paralyzed. Heart failure, venous insufficiency or varicose veins, venous obstruction from tumors, obesity, or pregnancies. So non-thrombotic lesion, and this is what I was telling you guys earlier, non-thrombotic lesions is compression. So you can see we have two diagrams on the screen here. We have one on the left and one on the right. So the pattern on the left side of the screen is the majority of pattern that is found in 75% of the patients. And what we're looking at here is the right common iliac artery crossing over the left common iliac vein, right where the fifth vertebrae is, right? So that happens in the majority of the population and of patients that we see. And also the second compression that we see is the right distal common iliac vein where the proximal common iliac vein confluence and the internal iliac artery dives deep into the pelvis. So that would be the second point we see diameter reduction. On the right side of the screen is the minority pattern, and you can see it's on both sides of the outflow veins. And so those patients usually present bilaterally, as opposed to the majority of the patients usually present unilaterally on the left side. So let's tie in the clinical piece using ultrasound. How can we identify these pathologies we discussed in the iliocaval system? Well, ultimately, we'd like to see them, right, with B mode. But I hear all the time, I can't see the outflow veins. The patient's ate already, they're not fasting. Or the patient is obese. Or this patient has been talking all day and swallowing a lot of air, and I can't see anything. So I'm here to show you that you can visualize these patients, right? You can see this, even in the most difficult patients. Patient positioning can help, and maneuvering your transducer can help as well in different aspects of the abdomen. But our goal as sonographer, right, is to answer the clinical question. Although, ideally, myself included, I'd like every ultrasound that I do to be pristine and textbook, but unfortunately, that's not real life. But what we can do in real life is answer the clinical question. And hopefully today, by the end of today, I can encourage you to embrace the tips and tricks that I'm going to show you that I've learned, and get the questions you need to help the physician, get this patient to the correct pathway. So what do I mean by if I can't see with B mode? There's something that we can do before we can even, place the transducer on the patient's abdomen, and that's looking at the Doppler waveforms at the common femoral level. The waveforms can give us a lot of information on what's happening in these outflow veins. Also, comparing the contralateral waveforms can also indicate if there's pathology indicated proximally that makes us want to investigate further. So let's pull up a normal venous waveform. And as you can see here, we have a normal venous waveform that displays phasic or retrophasic flow. Those two terms are used alternatively. So what is retrophasic flow? It's the cyclical increase and decrease in flow velocity that correlates to the respiratory phases. And what that means is that's the spaces between the waveforms. Another waveform that we need to pay attention to is a decreased flow, decreased phasicity, dampened flow, or blunted flow. Here we see less variation with the respiratory cycle than normal for this segment, or in comparison to the contralateral side. Continuous flow. So this ultimately means that something is obstructing flow proximally to where my transducer is located. This is telling me there's no cardiac or respiratory influences on the flow velocity variations. The spectral Doppler is steady and has minimal variations. absence of flow. So this is actually when you put that sample volume gate into the occluded vein. That means no flow is detected. And those pinging on the baseline is the adjacent artery, just pounding off the vein wall. So now that we have a good overview of the iliocable system, let's move on to the clinical assessment. To go further into Barbara's story, I need to take you into our time machine now for a moment and bring Barbara back into 2020 and pull up her images. So let's go ahead and pull up her images. So again, when Barbara had came into this lab at this time, she was positive for a deep vein thrombosis in her bilateral lower extremity veins. So when that happens, we had changed an algorithm in our facility that if we see thrombus at the common femoral vein level or bilaterally, to insonate the outflow veins, in addition to other factors which we can summarize at the end of this, this broadcast. So here we're going to look at Barbara's right common femoral vein. Her diameter is 1.2 centimeters or 12 millimeters, which is normal for common femoral vein. The normal diameter that's published is 12 millimeters at the common femoral level. Let's look at her waveforms. Her waveforms look good. They're retrophasic. The velocities are within normal range. Right now, there is no diagnostic criteria for venous flow velocities, but hopefully one day we will have them. But as for right now, we go by what the Doppler waveform display is showing us, whether there's retrophasic, decreased retrophasicity, continuous, or no flow. So we can see right here that her right outflow is normal. So I know, okay, noted, I don't need to go up higher on her. Her left side size is 13, which is, you know, still within the normal range. But her Doppler waveform looks a lot different than what we saw on her right side. So we have asymmetrical waveforms at the bilateral common femoral level, and her waveform is decreased as opposed to the other side. So I always checks and balance myself and just make sure that I'm not causing a false compression, because sometimes if I press too hard, I can cause a continuous flow, or my Doppler settings are off. So you want to make sure that all that is correct, so you know what you're seeing is true. So what I did is I went up ahead, and like I told you, you know, this is a limited protocol in our facility. You know, we're not adding on another hour to our exam and doing a full investigation of these outflow veins unless the physician orders that. What we're doing is answering the clinical question for the doctor, and by just doing a limited evaluation of the outflow vein on the side that's abnormal, like I said, I'm answering the clinical question. So that's how we changed the algorithm in our facility, in which we could talk about later if you're interested how we did it. So anyway, I used a curvilinear transducer and assessed her common iliac vein. And as you can see, we have a non-thrombotic lesion. We have a compression here of her left common iliac vein by her right common iliac artery. No thrombus is present. All right, so we have the answer we need as to why we have asymmetrical waveforms. So now let's go ahead and go to 2022. So 2022, we did an assessment of her bilateral lower extremity veins because she had came in with persistent swelling and pain, same symptoms she had in 2020, but since then was doing okay. So her right side was normal. She had some chronic changes in the vein, but ultimately nothing new, because what we've learned over in this space about venous disease is that clot begets clot, right? So somebody could have chronic DVT and then also get new DVT on top of that. So that's why it's important that we adhere to our diagnostic criteria as far as thrombus staging, and make sure we communicate that with our medical director, because not all the time we're on the same frequency as far as the criteria chart. So it's important that we nail that down with them as well. So anyway, I don't want to get too far ahead on that soapbox. So let's get back to Barbara here. So on the left side, she had new DVT that was entering into her common femoral vein. So immediately that instigated me to go up higher. But let's take you back to these ultrasound images real quick. So her right side is at 1, which is a little bit lesser than the normal diameter. Her waveforms look pristine, though. They're normal. I wouldn't say there's anything abnormal about this. I feel like there's good venous flow here, and according to my criteria, normal retrophasic flow. Her left side, normal vein diameter, a little bit smaller though, she's at 1. And then her waveform, again, looks decreased. So I know from Barbara's history that she has a non-thrombotic lesion, and the interpreting physician knows that as well. But it was important for me to go up there again and to look at it since she had another incident of DVT. So I'm going to go ahead and switch to the curvilinear transducer and investigate the left external iliac vein. And visually with B mode, like I was saying earlier, we can answer the clinical question real quick. So with B mode, you can see, there's no thrombus present here. So then I go up a little bit further, and again, I see that diameter reduction, and I also see my vein walls becoming thicker. The anterior wall of the common iliac vein is thicker. And then as I get to the confluence, you can see post-thrombotic luminal wall changes on the anterior and posterior wall of the left common iliac vein. On the left side of the screen, that's the right common iliac artery, and on the right side of the screen, that's the left common iliac artery. And right below that is the 5th vertebrae and into the inferior vena cava. So I'm just going to show you a couple images of this vessel here. And as you can see, there's another piece of the posterior wall that has luminal wall changes there on the left common iliac vein. On the anterior wall, there's some webbing there. And then again, you can see how narrow that flow has to get through. So as we go up into the outflow veins, these outflow veins have poor ability to collateralize because these are wide vessels, a lot larger diameter than the lower extremity veins. Like I said, normal dimension of the common femoral is 12, then we go 14 for the external, 16 for the common, and then 18 for the IVC. So knowing now we have that mental chart in our head, looking at these veins, you can see right away that this isn't normal, right? And then knowing what we know as far as diagnostic criteria for what thrombus staging looks like, this definitely fits into the category of chronic old clot. So immediately I put on color, but I like to use B-flow imaging because that allows me to pick up low flow velocities, right? So I really want to use every bell and whistle I can on my ultrasound system to see, one, if there's flow and what type of flow is there with Doppler. So this is B-flow imaging, like I said, and it picks up low flow velocities, and you can see that the vein is patent. But let's see what the Doppler shows us. So the Doppler shows us phasicity, which is impressive because sometimes you think arterial disease, right? So you're looking for a stenosis, you're looking for high velocity flow through this narrow diameter reduction, but that's not the case. So I've scanned a lot of these patients, and I'd say it only had a handful where there's been increase in venous flow velocity, where the pre-diameter reduction velocity tripled or quadrupled, right? Most of the time it looks like this. Most of the time it's old clot, the veins find a new way to reroute blood flow. And then the interventionalists will see collateralizations with venography in patients like this sometimes. So then I do additional measurements in B mode just to give the doctor good information, but I have to tell you, I did a lot more than I was supposed to on this one, just because I like to do more than I'm supposed to, I guess. But you could see pre and at the narrowest part of this, it's 1.8 millimeters, so it's really small, or 18 centimeters, 0.18 centimeters. And then as I go up to the IVC, the diameters go back to normal. And then, of course, I'm going to assess flow in the IVC, and again, respirophasicity is present in the inferior vena cava. So Barbara went to the interventional lab, and they do venography in conjunction with IVUS. So venography doesn't always show us a lot as far as diameter reduction, but it does show us a lot as far as luminal wall changes. What's interesting about this picture is that we can see a pre-dilatation before her area of interest, right? So that's a really cool finding to see on venography. And then I'm going to take you through the IVUS run. So here's the IVUS run where we're pulling through the common, and we're going up to the common iliac vein. You can see outlined in purple as we pull through the external iliac vein up to the common iliac vein, and then ultimately to the IVC, you're going to see the outline of the vein. And what they do is they measure the external iliac vein and figure out what the diameter reduction is in order to figure out the percentage of the stenosis. So here we are, we're pulling up towards the confluence now. You can see the artery pounding on the vein wall on the left, and then he's leaving the IVUS catheter there for a minute, and then he's going to come through to the inferior vena cava. As you can see, again, this is IVUS, so this is intravascular ultrasound. EVUS and IVUS correlate really well together, so I've always made it a challenge when I do these type of scans to see if I can match IVUS, and I always like to give myself a pat on the back when I do because it makes you feel good, right? But sometimes I'm wrong and it's okay, but I love to learn. So anyway, I'm going to pull up the next picture so you can see that they do diameter measurements with the IVUS, and they calculated a 63.3% stenosis, in which fits the criteria for her to get an intervention. So I'm just going to show you post-intervention. A stent was placed in her left common iliac vein, and that's a balloon angioplasty that they do to make sure the stent is adhered to the vein wall. So now I'm going to take you live scanning, but before I do that, I want to know if anybody has any questions as far as the lower extremity venous system, the outflow veins, any pathologies or diameter reduction that we talked about. I know we covered a lot in a couple minutes. Anything? Okay. All right, it's going to be a little cold. Put on the glove. It's going to be a little cold. So first thing I'm going to do is I'm going to do waveforms at the common femoral level because I want to make sure my outflow veins are good. And so we're going to do real-time information of that. Patient positioning is crucial as well. Right now I have Barbara in a little bit of reverse Trendelenburg, but I'm going to lay her flat for a second and just make sure her arms are at her side. Minimal movement. I always tell my patients, like, you can't really talk as much when I'm looking at your groin area because any movement or talking, breathing, respiration can influence venous flow. So I'm just going to lay her flat a little bit. Okay, a little pillow behind her head is fine. Again, I'm going to look at her common femoral vein on her right side, and then I'm going to look at her left common femoral vein, and then we're going to go to her left leg and show you her DVT and what it looks like now. Cool. Okay, sorry about that. Okay, real cold. All right, so visually, here's her sacral-femoral junction. I'm going to have her bend her knee and turn it out towards me a little bit, right into her groin crease here. So I'm going to scan up. So this would be mid-common femoral level. So you always want to start above the femoral head, right? So you want the vein to be right next to the artery, and I'm going to press down. So that's common femoral vein. Again, this is mid, and then the confluence distal is right here. All right, so I'm going to come up and I'm going to go in the longitudinal view, indicator towards the patient's head. I'm going to put my pulse wave Doppler down, color on that. And again, like I said, you don't want to make sure you don't press because you want to cause any variability to that waveform. I'm going to make sure my sample gate's at 2, so I get a nice sample. And then 60 degrees with my Doppler angle because we're looking at venous flow velocities with Doppler. So first thing I want to do is I want to decrease my sweep speed because I want to make sure I capture venous flow with multiple cycles over time. I'm going to invert and I'm going to bring up my baseline. Decrease my scale. Okay, Barbara, can you flex your foot for me, please? Do augmentation. Good, so we have respiroplasticity coming through. So what we can do here as well is we can adjust our wall filter. Again, that brings the Doppler closer to the baseline and then decrease our gain. Okay, so now I'm going to compare it to the other side. Cold. Okay, again, I'm going to make sure that I'm at the proximal common femoral level. Turn the indicator towards the patient's head. Okay, now can you augment your foot for me? Good. All right, very well. So right now we have pretty similar waveforms bilaterally. So what I'd like to do is just go ahead and move on to her left lower extremity vein, particularly her femoral vein and her pop area, because that's where her DVT was, and just give you a little information of what's happening in her inflow veins. So first thing I want to do is going to be a little cold. I'm going to go to her proximal common femoral vein and just bring my cursor up here so you can see vein 1 is partially compressible. This is your deep venous system down here. So the deep femoral vein, you got to think as the collateral pathway, as the femoral vein is the autobahn of the leg, okay? So we always want to make sure both are patent, okay? So then I'm going to start compressing down her leg, and you can see we have a little collateral here that's compressing, and then we have vein 1 that isn't, and this is the superficial femoral artery. So let me just image optimize a little bit, and let's go ahead and go in the longitudinal view, and let's see, again, this occlusive vein. You can see how it's filled with thrombus, low-level echoes. And also, when veins begin to heal, we know that the diameters are big because they compensate that 90 to 95% of that blood flow back to the heart. So as the vein heals, the walls become thicker and the lumens become narrow. And it's called post-thrombotic luminal wall changes. Sometimes it revascularizes and sometimes it stays completely occluded. And in Barbara's case, is completely occluded. So what we can do is when I have a situation like this, I show the doctor, you know, vein 1 is occluded, vein 2 is open. So you can see there's no flow here. And we're here in the artery. Come in. So now I'm going to go to vein 2. And we can see we have basic flow. Go ahead, Barbara, do an foot flex for me. Good, thank you so much. And flow augments. All right, so now let's go down to her distal area into the popliteal vein. I'm going to actually put you up just a little bit. All right, there you go. It's going to be a little cold, so I'm going to go in her distal thigh area. Sorry, it's cold. As you can see, we have a non-compressible femoral vein here. And you see the diameter is a lot larger. If you're unsure, you know, always put your color flow on. And let me just steer that. So we can delineate artery and vein. So you can see that's the artery on top and vein on bottom. Go ahead, augment your foot for me, please. There we go. We have no flow in that vein. So I'm going to go ahead and go to the popliteal area above knee, mid, and see what that looks like. A little cold. So as I scan up towards her head, this is the above knee popliteal vein. I'm going to bring my cursor up here. Here's the artery, here's the vein. I have a non-compressible vein. You can see the lumen. Let me just zoom that in. Let me show you a longitudinal view. There we go. So you can see that the vein size is large. And there's no color here. We're also going to put our Doppler down as well. Now we're going to come to the mid. A little bit more challenging. It's going to be a little cold, okay? That's fine. So this is the mid portion where the gastrocnemius veins enter into and the small saphenous vein enters into. So let's just look at her small saphenous vein here. So you can see that this is a good example of the patient's small saphenous vein extending up the thigh and not confluence into the gastrocnemius or the popliteal vein. So that's important information for the interventionalist. So you can see as I scan up towards her head, there's the paired popliteal vein right at the mid portion, and they're both occluded. So then as I scan down, you can see they're smaller in size and partially compressible. So I'm seeing belong here. And then we're going to head up to her outflow veins. So here we go. There's a beautiful vein here. We'll put our Doppler down. And you can augment your foot again for me. Good. Excellent. Okay, so now when we assess a patient post-operatively and her outflow veins, I'm going to start in her abdomen. It's important again that we look at the blood flow, what the Doppler shows us at the bilateral common femoral levels. So let me just go ahead and switch out my transducer. How are you holding up? Okay, good. Any questions so far about any of the images that I showed you as far as thrombus staging and flow characteristics? So I'm just going to plug in my curvilinear transducer. So typically when a patient has intervention, whether it's thrombectomy or stent placement, we surveil these patients over time. So it's a 1 month, 3 month, 6 month, 12 month, 18 months sometimes, depending on the physician, and then every year. And then if they're symptomatic, of course, we image more frequently. So automatically what I do is before I start looking at the stent, I'm going to assess the stent. It's going to be a limited protocol, by the way. So again, we're not spending an hour here. We're looking, one, especially since she's only has a vein in her left side, we want to make sure that the proximal stent isn't jailing off the right common iliac vein. So automatically I'm going to go up and just make sure that there's flow in the common iliac vein on the right side. And then I'm going to assess the stent in short axis view to see the adherence of the vein, the stent to the vein wall. And then in longitudinal view, I would do diameter measurements and flow velocities, prox, mid, distal, pre and post stent. For purposes of time, I don't think I'm going to do all that, but I am going to show you a couple tips and tricks because it is the end of the day and my dear friend has eaten and drank, but she did fast for us, so we'll see what we're going to see, okay? So I'm going to put my transducer down. So since I'm going right after my iliacs, I'm going to just start at the abdomen area. I'm going to look for my 5th vertebrae, which is right here on the screen. Here's the right side, here's the left side. So I'm going to bring up my depth. Okay, so here's my bilateral common iliac arteries, and here's that left vein stent right here. Just decrease. All right, so I'm going to follow my right artery, and I'm going to go long on that. And you can see in short axis, because remember, this is ultrasound, right? So we're looking at a 3-dimensional vessel 2-dimensionally, okay? So we're going to see parts of that stent. So you can see it looks short axis view here, but in reality, if you look at my transducer, I'm in the longitudinal view. So this is the IVC. Here's the right common iliac vein and the arteries on top. I'm going to put my color on. Again, this splashing of the color flow is due to bowel gas, so we can just image optimize again. And then I'm going to invert my color to put it on blue. So again, I don't see any aliasing here. Flow looks laminar. So I'm going to put my Doppler here. Again, and I'm going to angle correct here as well. So this takes a little bit of getting used to. I know when I first started scanning veins, I had to get used to micro movements of the transducer. It's not these big movements. It's actually the small movements of heel toeing the transducer and fanning medial and lateral. So you see how I got that right common iliac vein in. So we are going to pick up a little bit of artifact with the Doppler, but again, let's decrease our sweep speed, decrease our scale. So we want to put it to a venous setting. And then I want to bring my baseline up. I want to decrease my wall filter, get rid of the artifact on the top, and decrease my skip gain. And as I increase my sample gate size, you see how it creates more artifacts. So again, you want to keep it about 2. So let's keep that down to 2. Decrease our gain. And always, feel free to update your image as much as possible. So we have good flow here on the right side. So then I'm going to go up into the IVC confluence right here. So let's bring that in. Again, I'm going to heal up my transducer, fan a little medial. Let's get away from that bow gas. Put my Doppler right here in the IVC. Switch my Doppler angle. Come parallel to those vein walls. I'm going to invert. And you can see we have normal respirophasic flow here in the inferior vena cava. So I'm pretty confident blood is flowing great through the right side. So now let's check out that stent on the left side. So what I'm going to do is, again, I want to look at the external iliac vein, the common iliac vein. So a little hold here. Again, I like to do a lay of the land to figure out what approach is best, right? So we see we have the bladder here. We have the external iliac artery and vein. As I come up, they kind of fade out here, but we can still see bowel gas here. So we want to figure out how we can get the answer we need in avoiding this bowel gas. Well, we can come subpubital and image through the pelvic and angle up to see the external iliac vein. So we see we have a little bit of bowel dropout right here. So this is bowel, here's the femoral head, here's the iliac vein, and here's the stent, and here's the artery. So I'll put that color on so you guys can see. So there we go, there's the external iliac vein. Decrease my scale. Again, we check for patency just of the external iliac vein. Again, I'm going to get it more parallel to flow. Looks great. Okay, so now we're going to come up and we're going to look at the stent. All right, so you can see here's short axis view of the stent. Here's the proximal stent, here's the artery. Always put your color on and you can see the artery pulsating at you. So I'm going to scan up towards her head. You see here's the fifth vertebrae, right and left common iliac artery, and here is the stent, and then I'm heading up to the IVC. All right, so now I got a good lay of the land here. So an area of interest, right, sometimes we want to put our transducer down right parallel to the vessel, but when I do that, we have a little bit of bowel gas and we're not always able to see clear. So I can see my proximal stent edges, which is important. This is your distal stent edges, I'm sorry. That we look at this area because sometimes post-procedure this vein can spasm. So we want to make sure that that remains open and look for blood flow patency there, and which we see. And if we can't get a visualization there, what I like to do is image through different parts of her abdomen. So I would go and image through her psoas muscle. And how we find that psoas muscle is we go where the belly button is. We look for the common iliac arteries to split. I'm going to go over to her left flank here, identify her psoas muscle. You can tell by the striations here. I'm going to go long, and you can see the striations even more, and then I'm going to fan more medial. And you can see that opens up the stent really nice. And now I can see proximal, mid, and distal stent. So in order to get that distal stent edge, I'm going to come a little bit over here. You can always massage the bowel gas out of the way. But again, like I always strive to get textbook pictures. So to me, this is beautiful. So this is my distal stent edge. So I'd measure, and show the physician the stent is adhered to the vein wall. Look for any residual thrombus pre and post stent, and then of course assess blood flow velocities. So I'm going to invert my color so you can see that flow is basic. And then I'm going to follow that all the way up to the confluence. Right here. And I would do assessments of Doppler throughout. And then most important is I want to look at the inferior vena cava and make sure nothing's going on through there once I'm done assessing. All right, so once I get through here, I'm going to look at the inferior vena cava, which is right here to the left. Here's the aorta, and here's the fifth vertebrae. I'm going to go along the inferior vena cava. Again, we have the bowel gas overlying over here. Again, I'm going to put my Doppler down here, which we saw, and this would be our proximal stent into the inferior vena cava right here. So if I towed down my transducer, probably get a better image of that. Yep, just like that. So again, if I have issues imaging the proximal portion of the stent, I'm going to come all the way up a little bit higher and kind of angle down where I would be looking at the SMA and IMA up in this area. Come up a little higher and angle down. And then ultimately, if I can't see, then I'm going to turn the patient on their side. And I'm going to follow that all the way up until their heart. There we go. So always remember that inferior vena cava is to the right of the spine. So here we have a beautiful image of proximal, mid, and distal. And I didn't even have to, maneuver my patient too much to get this image. Another tips and tricks I always, as far as patient preparation, right? So again, we always tell our patients to come in fasted. We give them, ask them to take bowel gas, Gas X, right, the night before and the morning of. Again, the more they talk, the more they eat, the more they drink, the more air they're going to swallow, so it becomes trickier, right? To assess these veins. And like I said earlier, I always like to show beautiful pictures, but unfortunately that's not always the case. So again, knowing that there's different areas that you can look at. So for general sonographers, right, you want to look where the appendix is located, right? So you want to look right over here through the psoas muscle. It's going to always show you the distal. Let me just write it down. Show you the distal inferior vena cava into the confluence of the iliac veins. So again, through the psoas muscle, I'll show you what it looks like on the right side. So again, you want to go to where the common iliac arteries are, and you want to split them, and then you want to move your transducer over to the right of the patient, and that's your psoas muscle, okay? So then you're going to go in a longitudinal view, and you can see the muscle striations here. And then you're going to angle medial, right? So there is a nice, beautiful image of the inferior vena cava into the right common iliac. And again, that's the left. So you can also get confused if you over-angulate, right? So if you over-angulate, you're going to pick up the left side. So you always want to look to see where your transducer is on the patient's body, and then also maneuver your transducer as far as the anatomy is concerned. And remember, the IVC is always to the right of the spine. All right, so then that left side again, you would do the same thing like I showed you earlier. Psoas muscle. Again, answer the question, is thrombus extending into the IVC? Is thrombus in the common iliac vein? Right, so you would just answer the clinical question real quick here. So that's the psoas muscle. This is my go-to. And if I have an issue with seeing the external iliac vein or its proximal portion into the distal common, I always like to image from the pelvic, right? So either from the right or the left side. Sometimes I'll go more medial and just go on top of the uterus here so I can see this is my right side here on the left side of my screen. So I'm going to go in the longitudinal view. You can see the femoral head here, and then we can follow it all the way up. As you see, got a really nice view of the external iliac vein. And then again, you don't want to over-angulate. So here's the artery and here's the vein right underneath. And then always throw your color on to help you guide you through. So when I'm scanning veins, I think arteries, right? And when I scan arteries, I think veins. So I let my arteries guide me to where I need to be. So again, I'm going to put my color on again, and you can see the external iliac vein really nicely. See there's flow here. Again, if we can't visually see with B mode, always go with Doppler and color. Doppler down there, so you can see there's phasicity here. So I'm really confident I'm not missing anything. So I know from where my transducer is located and above, I'm good. Even if I can't see with B mode, I'm relying heavily on Doppler. So again, make sure you're not pressing too hard, because I'm going to show you if I press too hard out, I can do a false elevation. So this can be a false positive on a patient. So if I press too hard, you see how my venous flow velocities increase, and you see how continuous the flow becomes. So again, you can cause a false positive as well. So you always want to make sure you're light with your transducer, right, on the patient, and just let the venous flow come across nicely on your display with Doppler. Same thing with the left side as well. If there's bowel gas in the way, I always just take my transducer and I just gently massage the area a little bit. And that usually helps move it out of the way. But again, the things that are going to affect your venous waveforms, especially if you're in the hospital or vented patients, so sometimes that can be tricky as well. You're going to have more gets harder to delineate what's normal and abnormal. So again, do the best you can to identify with color, B mode, and Doppler. Put all the pieces together so you can tell your story to the doctor appropriately. So let's go ahead and see what the left side looks like imaging from the pelvic. Here we go. There's the vein. Here's the artery. There's her bladder. We're going to go up and then along. You also want to make sure the patient has an empty bladder if you can, if you're in an outpatient setting when you do this exam, because that can also cause a false elevation. So again, we have the bowel gas like we saw earlier. The color here, you can see we have good visualization of the artery. So I'm just going to fan my transducer more medially. And you can see I have my external iliac vein coming really clear here. And again, I want to be light to touch. So that I can come more medial and scan outwards. And there we go. We can just focus on the vein right here, because in the other view it looked very small. Again, normal phasicity, and I'm going to press again, and you can see how I can cause continuous flow and increased flow velocities. So very important that you're not pressing, okay? So light to touch, I can't stress that enough. And then I'm going to scan up, and you can see we have just bowel gas interrupting the distal part of the common iliac vein and the proximal part of the external iliac vein. Any questions from the chat so far? Oftentimes, if I can get lucky enough, I can use actually the linear transducer. So what I'm going to do is I'm going to switch that out. And some facilities actually don't have access to a curvilinear transducer. So I would just activate the linear transducer and plug it in and just see if I can get a better image with the linear transducer. So let's just see what that looks like as well. Okay, cool. So again, I would go to the same locations, right? So it's just gonna look different on your screen, right? So the arteries and the veins are gonna look bigger, but you can see, even with the linear transducer, I'm at 5 centimeters depth and I have a nice view of my external iliac vein. And then as I scan up, it starts to dive deep down in the pelvis. Well, let's see if I can get it up here with the psoas muscle. Okay? So again, here's the common iliac arteries and the vein. And we can just look at that stent with the linear transducer. Okay, there's 5 minutes left. And so what I'd like to talk about is the Zoom call afterwards. Again, I went over a lot of material and I felt like I talked really fast and I told you a lot of information in a methodical order, I hope. So what I'd like to do is really get to meet you guys personally and talk to you one-on-one. If you guys have any questions as far as imaging and what I can do to help you, now would be the chance, because I'd really like to show you live what I would do in a situation if you have a technically difficult patient. So this is the Medtronic stent that was placed in here. So that's the one they were using in our facility. Any other questions as far as stent assessment? Or any tips and tricks you guys may need as far as looking at the outflow veins or DVTs? All right, well, I will see you on the Zoom call.